This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo, and this week I'm coming to you from the W.L. Nugent Cancer Center at KRMC. According to the American Cancer Society, breast cancer is the most common cancer diagnosed among women in the United States. It is the second leading cause of death from cancer among women. Only lung cancer kills more women each year. This week, we're talking about the importance of genetic testing in detecting and treating breast cancer. My guests are Dr. Edgardo Rivera, he's a medical oncologist here at KRMC, and Rae Timm, she's the lead LPN. Welcome.
Thank you.
We have long known that early detection is critical for surviving cancer, and KRMC has the Catch It Early program, which provides screening mammograms at no out-of-pocket costs for uninsured and underinsured women in Mojave County. Dr. Rivera, how common is genetic testing for breast cancer?
I think we need to really understand first what's genetic versus what's hereditary.
Please.
Right?
Yeah.
So there's a difference between having a genetic cancer versus hereditary cancer. So all cancers are genetic, right? So remember, cancers are just normal cells that change over time. They go through genetic mutations and they lose their ability to die. So technically, all cancers are genetic. The question is whether the cancer is hereditary, whether the person was born with a genetic predisposition to develop cancer, right? So that's the difference. And that's the importance about genetic testing and understanding the difference between something that is genetic versus something that is hereditary.
Yeah, that's a great point. Genetic and hereditary in other contexts are sometimes used interchangeably, right? Or not
They
so
are,
much?
and some people sometimes get confused about that.
Yeah.
The reality is all cancers are genetic.
Right.
All cancers are caused by some sort of genetic mutation. Most of them are caused by either the environment, lifestyle. Smoking, for example, is the most common cause of lung cancer. Diet, obesity. That's different from being born with a high predisposition or a hereditary predisposition to develop cancer.
Understood.
Most cancers are not that way, so most people are not born that way. But there's still a small percentage of patients that have a high risk of developing certain type of cancers. So.
Right. Great distinction, and thank you for that. And we'll talk more as we move on about the parameters for breast cancer screening, which is always recommended, correct?
Correct. We do want everybody to get screened for breast cancer using mammograms.
Correct.
The question is, when you talk about genetic testing, who's the right person to have genetic testing and who's not?
Well, who is?
Exactly.
Well, who is? I'm asking you because
you're asking
the doctor.
me. Okay. So normally, there's a whole criteria that we use, right? There's some cancers that are definitely more common in which there's going to be some sort of a genetic predisposition, in which there is a hereditary predisposition. Normally, you talk about cancers like breast cancer, ovarian cancer, colorectal cancer. You don't talk about that in lung cancer, for example, because we know that 95% of lung cancers are caused by smoking. Same thing with bladder cancer. Number one cause of bladder cancer is smoking. But there's other cancers like breast, ovarian, prostate, pancreatic, and colorectal. All those not only can have a component of being developed by your lifestyle and environment, but there are also a small percentage of patients that were just born at a higher risk, right? So the question is, who is the right person to be tested? We have the American Society of Clinical Oncology, and every year they publish these guidelines that we use in terms of who should be the right person to undergo genetic testing. We know that most cancers tend to happen in people as they get older. You don't see normally somebody with breast cancer in their 20s or 30s. Those are not very common. Most breast cancer happen between age 50 and 69. So for example, if you have a patient that comes and see you and is somebody who's younger than 50, and especially if they have a very strong family history of either breast or ovarian cancer, or even a history of prostate cancer and pancreatic cancer, or they have a personal history of a different type of cancer as well, like ovarian in the past, those are the patients that you have to think about, do they need to have genetic testing? There's also specific type of cancers that it really help us have an idea of whether they should be tested or not. The perfect example is when a patient comes with what we call a triple negative breast cancer. The patient has already been diagnosed as a triple negative breast cancer. That is a very aggressive type of cancer to have. Those patients nowadays are recommended for all of them to be genetically tested. Because if you are born with a genetic predisposition to develop breast cancer, the likelihood is that you're going to have a triple negative breast cancer. So just because you have a triple negative breast cancer doesn't mean you have a genetic predisposition. But if you do have a triple negative breast cancer, you definitely should be tested. The guidelines now recommend also for all prostate cancer patients to be tested, newly diagnosed. Also, all pancreatic cancer patients and all ovarian cancer patients, they should be tested. So there's certain things that we looked at. We look at diagnosis. We look at the age when the patient was diagnosed. We look at their family history, and it's not just having family history of any type of cancer, because sometimes we ask the patient, well, tell me more about your family history. And they tell me, oh yeah, I have a family member that died of lung cancer, but they were heavy smokers.
Sure, right.
But if they tell me, by the way, I had a sister that was diagnosed in the 30s, and I had another sister that was diagnosed with ovarian cancer, right? Or my father was diagnosed with prostate cancer. Those are the things that should make an oncologist think about the possibility of genetic testing for that patient.
So it sounds like one of the keys here is to have those conversations with your doctor.
Correct. And medical oncologists are actually trained to be able to answer those questions. So somebody who wants to come and have genetic testing, they can make an appointment and decide whether they should really fit the criteria, whether they have the right patient, if they're the right patient, even if they've never been diagnosed with cancer before. Remember, there's two, that's the part that we want. We want to be able to catch people who are at high risk early on before they get diagnosed. So either a patient who has been diagnosed in the past and they want to be tested, we talk to them, we tell them, yes, you probably are at high risk. There's a good chance that you'll have the genetic test positive, that you have some sort of mutation, or someone who's never been diagnosed before, but they're concerned because they have a very strong family history and they want to be tested. We get those patients all the time.
Yeah. And this genetic testing, I think you anticipated my question, it can show you signs before, for example, the annual mammogram can.
Well, it's a little bit different than that. So
Okay.
it doesn't show you signs. What it's telling you is whether the specific patient, right, is going to be at high risk of developing cancer throughout their lifetime, right? It's very specific because we look at different genes. These are genes that you and I have. Everybody has them. These are genes that are oncogenes. These are genes that are there to control the growth of cells, essentially to prevent your normal cells from developing into cancer. But when those genes get mutated, right, and based on the mutation that is present, then we have, and based on data that has been collected over the years, we know for that specific patient what's going to be the risk of developing either breast or colorectal or ovarian or prostate if it's a male, or male breast cancer or pancreatic cancer, right? The other day I had a patient that I tested her thinking that she was going to have a high risk of developing breast cancer. She already has been diagnosed with breast cancer. Interesting enough, she did not test for a gene or a mutation that would put at risk of breast cancer, but we found out that she's at risk of developing melanoma, which is, a very lethal type of skin cancer. So what we did was we sent the patient to dermatology to be seen, to be screened.
And then she would know with that to have her regular follow-ups with dermatology to make sure she's not developing any abnormalities.
Right. And Rae, you're right on time. I wanted to bring you into the conversation. As the lead LPN here, you coordinate, my understanding is you coordinate the genetic testing.
Yes.
Can you
that's
talk a little
correct.
bit about that process?
So once the patient comes in and Dr. Rivera and the patient decide that this is the best course of action, we have the patient actually head right over to our lab with a fancy little box. They have a very easy blood draw, and then they return the box to us, and then we send it to a company that does the testing for us. And then those results come back usually within 14 days-ish. Once those results come back, depending on what those are, if it's negative, it's usually a quick phone call to the patient saying, hey, everything came back negative, nothing to be concerned about at this time. Or if they did come back with an abnormality or anything like that, we would have them come back and have more counseling with Dr. Rivera.
And what do those next steps look like if it is positive?
So if it were positive, usually we're able to get patients in fairly quickly, usually within 3 to 5 days, and not generally longer than that. And then they would talk with Dr. Rivera about the risks that their mutation has. With some of these companies that we use, they also have genetic counselors that are available. I believe one of our companies, if they've tested positive, they will test family members also. Most of these are covered by insurance, and the companies we use are very good about financial assistance if it exceeds a person's budget.
Yeah, you anticipated that question as well. No, that's a good thing. We always have to talk about it. It's the unfortunate reality of medical care.
So what I was going to say also is the fact that, like Rae was saying, once we know that the test is back and the test is negative, they just give the patient a call. We don't give positive results on the phone. They meet with me because medical oncologists are trained in being able to do genetic counseling. Some hospitals do provide on-site genetic counselors there. Those are very difficult to find. It's not like there's a lot of genetic counselors out there. And some of the companies that have their own genetic counselors. So if they want to specifically talk to a genetic counselor, we give them a number and they can call, right? And they can help them decide what would be the best thing for the family members, right? When I meet with the patient, then I talk to the patient in terms of the risk. You have to keep in mind that there's different situations that we're doing genetic testing here. We do it in patients who perhaps have a high risk of developing cancer or that we suspect they have a high risk, but who have never been diagnosed, okay? But we do it also in patients who already have a diagnosis, right? Especially if they're newly diagnosed, to help them decide what will be the next step in their treatment path for their diagnosis. The perfect example is breast cancer patients. We have breast cancer patients that come in, they get diagnosed with breast cancer, and I like to see them first, and most medical oncologists see the patient first, because if we suspect that the patient is at high risk of developing breast cancer that has some sort of genetic predisposition, then it will help the patient decide what type of surgery it's going to have. Does the patient want to have breast conservation, or the patient wants to have bilateral mastectomies, right? Wants to have a mastectomy of the one that is being diagnosed with, and a prophylactic mastectomy of the contralateral breast, of the opposite breast. It's going to help the patient decide, do I need to have my ovaries removed at one point, right? Some patients come where they already have their ovaries removed, but some patients are not. If it's a younger patient, I never had children before, do I want to have children now and then wait to have my ovaries removed? All that a patient's going to need to have an idea of what would be the next steps, right? All that is very good for the patient, especially at the time of the surgery. But you also do genetic testing nowadays because there are a lot of different drugs that have been developed nowadays that are specifically for patients who have a diagnosis and that were born with some sort of genetic mutation, or that their cancer has that genetic mutation. And that's the therapeutic part, in which you do genetic testing to help decide what would be the best treatment option for that patient. So there's almost 3 different aspects. For patients who have never been diagnosed, that you suspect they're going to be high risk, it helps them do the surveillance for the patient. Do they want to have, for example, in breast patient, do they want to have an MRI, and do they we offer them to see them every 6 months. A lot of insurance will pay also for not only the mammogram, but it will pay for an MRI of the breast. If it's a male, are they at risk of prostate cancer? Do they need to start being screening for prostate cancer, being seen by urology or by the primary care provider. If he's a patient who's going to be a high risk of pancreatic cancer, right? Nowadays, it's recommended for them to have what they call an MRI of the abdomen or MRCP to screen for pancreatic cancer at least once a year. So that's the one component, right? And then there's a component of patients already have a diagnosis, and it helps them just mostly in deciding next steps during their treatment, right? And the therapeutic aspect, patients who need some sort of treatment, some sort of systemic treatment, all these new drugs that are available that we can give to patients who carry those specific mutations. So it's a little more complex
For sure.
than people think because of all the different aspects that involve doing the genetic testing.
If you're just joining us, I'm T.G. Lafredo. This is Focus on Your Health, and this week on the program, we're talking about the use of genetic testing in cancer treatment. My guests are Dr. Edgardo Rivera, Director of Oncology Services at Kingman Regional Medical Center, and Rae Timm. She's the lead LPN at Dr. Rivera's clinic. That decision to have those radical surgeries, on the one hand, you're faced with the possibility of a very aggressive cancer that could take your life. On the other, it's still so personal, and it must be a really difficult. Could we talk a little bit about that process and people kind of wrestle with that decision?
It's a very personal decision. Some people are so afraid of that C word, the cancer. Others are not that way. They're polar opposite. They want to conserve as much as possible because I think some people feel mutilated. I have a family member who has breast cancer, and she leaned more towards the please just cut everything off because she was fairly young when she was diagnosed. So she would much rather have had the longer life and get rid of everything than worry about cancer coming back. She was more comfortable having her both breasts removed and actually fought for that. And it turns out because she ended up progressing many years later that she needed to have those mastectomies done. I think a lot of women are, because your breasts are part of your femininity. It's what you use to nurse your babies and all of those things. So I've heard many of our older patients, they seem to be more comfortable with the loss of a breast than some of our younger patients. And I think I've heard many times, I don't need them anymore, just take them off. Where you don't necessarily hear that as much from our younger patients, I think. And I think that's because they're younger. They want to conserve their bodies as much as possible. And it has to be what's right for the patient, what they're comfortable with.
What does the counseling look like in that regard when you're sitting down and chatting with a patient about these decisions?
And again, there's two different types of patients. There's a patient that has never been diagnosed, but comes to you asking for genetic testing because they know that they have a very strong family history, right? What I've learned over the years, that those patients, if they're already reaching out to you in terms of asking for genetic counseling, is that they're definitely very open to having their breasts removed or their ovaries removed if they test positive, right? And then there's patient who has already been diagnosed, right? So if they do test positive, what I've also encountered is that those patients, the likelihood is that, except for a few exceptions, is that they're more than likely that they're going to want to have the other breast removed because they already had a scare, right? We do talk, especially somebody who's never been diagnosed before, when we do a genetic test, that comes back with a percentage of what the risk will be over their lifetime in terms of developing X or Y cancer, whether it's breast or ovarian, whatever cancer it is. And because it's based on the gene that is mutated and the type of mutation, right? But we can give them a percentage. Some as high as 80%, some are probably low as 20%. But we're talking higher than the average population and higher than even people who have some risk factors. People who are born with a genetic predisposition, they're going to be at the highest risk of all, right? So we talk to them about it. They know the percentage. What I've seen is that normally we have patients that get tested. We give the results to the patient. The patient reaches out to their children or siblings, and we never hear anything from the children or the siblings. That's very common.
You want to hear from them. You
correct.
want them to follow up.
You want to hear from them.
Yeah.
And again, the ones that do reach out are the ones that tend to be very open about whatever change, whatever will be the most effective.
Right.
So.
Right. For a long time, we've pushed the idea of making a yearly mammogram, part of the habit. We've removed a lot of the barriers. Still, we hear stories about women who say, I'm afraid of what I'll hear. I don't want to go in and find out. It might be bad news. I don't know how to deal with it. Or even my mother or my aunt went through all that. I don't want to think about it.
But there is. We still see some denial. We still see patients become very, very advanced.
Yeah.
We just saw one patient yesterday who came in with a very large mass in her breast, and quite advanced. And the patient unfortunately had not had a mammogram in several years. So we still see some of that. But to be honest, I can tell you that we're seeing more and more patients being diagnosed earlier. And part of it is because there's a lot of education, program like yours, for example, that helps.
Thanks for the shout out.
But also, there's a lot more education about it, but technology has gotten better.
Yeah.
So then they're able to find things a lot earlier. So the survival is better, prognosis is better. Nowadays we cure over 90% of the all breast cancers. Yeah. So
this is not what you saw in the beginning of your career.
Correct. Yeah, right. It was more patients who came very late. A lot of patients with stage 3, stage 4. We see a lot of patients now with stage 0, stage 1. Yeah. So it's completely different.
For a listener who's saying, Dr. Rivera is talking about me right now. I have a history of cancer in my family. This pertains to me. What is the next step? Do you talk with your general provider? Do you give a call to the cancer center? What's the next step, Rae?
So you could do either of those things. It's always good to talk with your primary care provider about any of your concerns, but they are always able to call here. We would get some information from them, and then if and when it's appropriate, we would have them come in and meet with Dr. Rivera and go right through that process.
A lot of times their patients are diagnosed by a surgeon, or they go see a surgeon first, and the surgeons, because they work with us so much, they'll send the patient to us first to be genetically tested if they feel that the patient has a high chance of having a genetic mutation, and that is to help the patient and the surgeon decide what would be the best surgery for the patient to have. So we get them through the surgeons as well. Yeah. So
I would just encourage with those mammograms that for those that are afraid, don't be afraid. It's not painful. Especially here at our breast imaging center, the technicians that do the mammograms are very compassionate and make you feel very at ease while you're there. So do your screenings.
For more information on genetic testing at KRMC, you can call 928-692-4666. That's 692-4666. You've been listening to Dr. Edgardo Rivera. He's an oncologist here at KRMC. And Rae Timm, she's the lead LPN. Thank you both so much for your time today.
Thank you for having us.
And that is the program. That's Focus on Your Health. I'm T.G. Lafredo, and thank you for listening. We'll catch you next time.